Let's talk about safety, because the sticking point is, I mean, what you always hear is, oh, sure, it would be much more pleasant to give birth at home, but it's so much safer in the hospital.
We really just don't have any data for that at all. When birth moved into the hospital, infant mortality rate rose, maternal mortality rate rose. It did not go there because it was safer.
Yeah, and many Americans don't know that. That historically is very true. In the 1930s, as women, the majority of women began to birth in the hospital, the death rate of mothers and the death rate of infants actually went up quite significantly.
By city, you can show Newark, New Jersey, New York, and there are different studies people have done each time. When you moved it in, it wasn't over safety. Okay, that was then, this is now. Absolutely, hospitals have gotten considerably safer than they were in many ways. They're not as safe as home. The longer you're in a hospital, the more likely you are to pick up an infection for both babies and mothers. You just put a whole bunch of people together in one place, and you're more likely to have infections in the hospital than at home. You're more likely to need and receive, or receive and need, I'm not sure what the order of that is, all kinds of interventions in the hospital that are themselves dangerous. One of the problems we have is sometimes people, collect home birth statistics, and they'll look at every 7th month fetus that unexpectedly birthed on the bathroom floor.
And that becomes part of the home birth statistic.
Right. If you look at planned home births, they're safer. Controlling for anything anybody's ever been able to control for. Planned home births are safer than planned hospital births. There are occasional women for whom you wouldn't plan a home birth. Somebody who has a particular illness, condition, whatever.
Let's explain what's safer. By safer, you mean?
Healthier outcome for mother and baby.
Less morbidity and less mortality.
Less mortality.
Right. Fewer deaths and fewer illnesses.
Yep.
It's safer at home.
Safer, yes.
Let's talk about the cesarean section rate, because this is what's really in the news today, and most Americans are aware that we've gone from a roughly 4% C-section rate in the mid-1960s to the rates that just came out last year are almost just a fraction away from 30%. It's quite extraordinary.
Yeah, it's pretty amazing.
And how do you explain that?
Well, it's one of those, one thing leads you into another life experiences. They started doing fetal monitoring, and they had no idea what that monitoring meant. So it wasn't like you did a whole lot of it, observed many, many fetal strips, and then decided what outcomes were best.
Exactly. It's okay, the baby's heart rate is very, very fast or very, very slow. Is that good? Is that bad? Is that normal? When you had that fetal monitoring, people weren't really sure because they'd never monitored that closely before.
But they got nervous and they started doing the cesareans. You have an interesting ongoing de-skilling of physicians. If you start doing cesarean sections, say for breech births, you end up not having, a physician who's never done a breech birth ever, you would not like them to start on you. So if all they know how to do for breech birth is a cesarean section, they're de-skilled, they're going to have to do that. The basis on which they do it, the doctors are much more confident in some ways with the C-sections. It's much more a controlled procedure. They know when they start, they know when they end, they know what they're doing, they feel totally on top of it. It's more dangerous for women, for sure. The infant outcome, it's really tricky to figure out what you need to control for, because somewhere in there is the 4 or 5% that maybe we ought to be doing. So it's kind of hard to get the hard data on that. You do know that you're more likely to cause long-term and short-term illness and death in the mother if you do abdominal surgery on her than if you don't. That should be fairly obvious.
The death rate of women is actually 6 times higher in section births than in vaginal births.
And again, some of that, a few of those, are women who are having the section because they are in danger anyway. But not when you're talking about a 30% section rate anymore. Okay, by now it should be a negligible difference between those if the section was safe. But it's not. How could it be safe? It's not. So yeah, we're risking the lives of women and babies.
You know, induction too is another, it's almost, I know from our own local hospital here, I hear stories about how it's almost unusual to have a woman come into the hospital already in labor, that you make an appointment and you come in and you're induced. And this is very, very common in hospitals all over the country now. And I wonder what kind of an effect that has, not just on women physically and on their health and on the baby's health, because we think now it's the fetus that triggers labor. So what does it mean if we do that artificially? But I wonder what that does to our view of birth as well, when we make an appointment and we come in and we get an IV.
It reinforces that the birth is essentially a surgical procedure. I mean, it's managed in every which way. Every cue available to you is that you go in to have the baby removed, and that is a surgical event. And obstetrics is a surgical specialty. I mean, there's every cue available to the man from Mars is that birth is a surgical event. You have to really see a woman give birth in a non-medical setting, just to imagine it.
Yeah. And there are several editions of your book, In Labor, that are out. And I know in your first edition you said you were writing it with great optimism, and this was in the 1980s. Then in your 1991 edition, you said, which is now 15 years ago, you said you were writing it with more cautious optimism. And I'm wondering now today.
What a sad question. No, yeah, it's really hard to be optimistic.
And that's an amazing turnabout in 20 years. I mean, you've gone from very optimistic to cautiously optimistic to...
kind of miserable. I spoke to a British midwife who was just about to retire. And she said, I'm trying to come to terms with the fact that over the entire course of my career, every single thing I care about has gotten worse. And I was comforting her and thought, though, well, God, it's a good thing I'm an American, because things were so bad here that you can say it's gotten worse. That when we came in, like the point that she came into her career, I guess in the early 60s, most of the British births were managed by midwives. By the time she was retiring in the late 90s or whatever, they'd lost a lot of that. They'd had a big home birth movement. They'd lost that. I mean, things were going really quite bad. Here, what's happened is we've replaced cesarean sections. We've used those instead of making women heavily drugged throughout their labors, making them pretty much unconscious for their births, strapping them with metal straps, using forceps. I mean, that was the normal obstetric practice. Now the normal obstetric practice is to leave her mind clear, do an epidural, and surgically remove the baby, as the docs like to say, from above or from below. I mean, either use an episiotomy and get the baby out by below, cut her abdomen and get it out above. But it's so fundamentally remained a medical event that you can't say things have gotten worse here. But the hope that we had there for a while, that a midwifery alternative would become a stronger, more present voice, it's questionable. I mean, there is a good, the Midwives Alliance of North America is the umbrella organization for midwives. They have active work. There's a website. Go look up the Midwives Alliance of North America. Give them your support. It's there, and that is a source of optimism.
You know, healthcare costs are such a big issue today. Wouldn't healthcare costs go way down if we had the midwifery model and only had women who were clearly in danger, clearly had problem pregnancies, birthing in the hospital, and assigned midwives as opposed to trained physicians, as opposed to physicians who are specialists?
I think that's probably true. It would certainly go down because the health outcomes would be better, and that would, long term. I hate to talk about this in terms of it's cheaper, because probably the cheapest thing to do is mass produce these things in the cheapest possible way, very in and out births. People complain so much about the, quote, drive-through delivery. I mean, I think, it'd be best to just stay home or get out of there as fast as you can. But saying we're going to do this on the cost basis, I think if you're talking about a trained midwife being available to a woman for the whole of her labor, for staying with her afterwards, for coming back and seeing her the next day, for coming back to her home, seeing how breastfeeding is going a couple of days later. If you're talking about a trained person who's really devoting time, yes, that would probably cost, it's a sad thing, less than the hour of the obstetrician's time. Obstetricians are so well paid. But I'd like to see midwives well paid.
Thanks so much to Barbara Katz Rothman for our discussion on obstetric practice in the U.S. Please join us next week when Barbara returns to talk about prenatal testing. For upcoming episodes, viewer feedback, and links to important information, log on to our website that appears on your screen. Thanks for joining us on Health Vision, a production of WOUB Public Television.